APRV uses continuous airway pressure with brief releases to evacuate CO2, often termed bulk ventilation. So in this mode, if you look at the pressure time waveform, it looks like CPAP. And what's the purpose of this CPAP, which in this mode is called a P high? It's basically to recover that patient's ideal functional residual capacity, right? To recruit the lung and to put the lung in a more optimal and compliant area on the pressure volume loop. We know that if the lung is being ventilated on the lower aspect, that we're basically experiencing atelecta trauma. The compliance is really poor at the base there, at the start on the left of the pressure volume loop, requiring lots of pressure and lots of work of breathing to initiate that breath. And if we're overdoing it with the pressures, if we're pushing that patient with too much of a FRC, then they're also going to lose the compliance because you're pushing them up towards the higher aspect where you're going to get hyperinflation. When you have the hyperinflation occurring, that flattens out the diaphragm, and now you're going to have a patient that's breathing really shallow and over distended. So it's important to approach the patient and this kind of mode with the understanding that we're going to be setting that P high, which is basically a CPAP, to optimize the patient's FRC. We know that when a patient is sick or there's an altered chest wall compliance, we got ascites, anything that will put increased pleural pressure will also put a lot of pleural pressure, will create a negative transpulmonary pressure where the outside of the lung has more pressure than the PEEP that we're setting, and obviously we'll get the alveolar collapse. So during the pressure release phase, like I had mentioned, that's where the CO2 will be evacuated. So during the P high phase, the lung is supposed to be splinted open. There's supposed to be recruitment that's occurring over time, and that should increase the amount of surface area where diffusion is occurring at the alveolar level, right? So when that release, that bulk ventilation, that drop occurs, that release of the airway pressure, a lot of CO2 is evacuated, okay? During the release phase, it's important to understand that this is a very, very brief release, okay? The alveoli are not collapsing. We're not allowing this drop to cause any de-recruitment. This is why it's a very brief drop, and what we're going to do is we're going to create such a low release time that we're going to create the air trapping. The alveolar stability occurs when we trap about 75% of the peak expiratory flow. So we have the peak expiratory flow, let's say 100 liters per minute when that release phase occurs. And if that's 100 liters per minute, that means that once the flow descends to 75 liters per minute, we are stopping that exhalation and returning back to the P high level. So it's very important to take into consideration we are not allowing significant deflation of the lung. When you look at the amplitude of ventilation during these releases, there's almost no chest wall movement. So this is a ventilatory mode where the patient can breathe spontaneously throughout the whole respiratory phase. Therefore, when they're in P high, they should be able to breathe quite comfortably, because the whole point of the CPAP level, that P high, is to put them into a corrected FRC where they're able to breathe on the pressure volume loop, as mentioned before, in the most compliant areas, okay? It can also be used in an apneic patient as well. But it's definitely a mode that encourages spontaneous ventilation. The minute that you are intubated, we should be concentrating on getting this patient extubated as soon as possible. So correction of the FRC, facilitating work of breathing, and an early start to spontaneous ventilation, spontaneous breathing, and encouragement. And they should be able to breathe relatively quickly, even if they have a pathology, even if they're fairly critically ill. Still, if they're able to breathe spontaneously with a decent work of breathing, this should still be an option, all right? What's also very useful is looking at the flow time, okay, waveform. You want to see nice like hills, not peaks, not steep mountains on those flow waveforms, and also not like shallow, tiny little bumps, okay? So if that patient is pulling and you have the very high amplitude flow time waveforms, they might be on the lower side of your pressure volume loop, and the patient's pulling, trying to recruit back the functional residual capacity. So sometimes you'll have a very high amplitude on the flow waveform when you're on the lower part, when you're possibly, not high enough with your P high. But also you can also tell from the flow waveform if you're too high, right? If you're on that hyperinflation aspect of the pressure volume loop, then you're going to have, right, the shallow breathing because of the flattened diaphragm. You're hyperinflated, so you'll typically see these, tiny bumps. Now, this picture above is not ideal. I was trying to create it with just a regular artificial lung, so it does look quite choppy, but it's important to pay attention to the flow time waveforms. It will give you information about possibly being too low with your P high, and vice versa, also possibly too high with it. You may also see on the P high, when you're on the P high, that there's literally an erosion of that CPAP level. When the CPAP level, the P high is not set high enough, you might have literally the patient sucking down that CPAP level, eroding it, just trying to generate that high flow, and they're sucking back and pulling down the P high. That's an indication probably that you're very, very low on your P high. You should be going higher. So recruitment is not only about pressure, it's pressure in relation to the time, right? So that's why recruitment maneuvers are done with pressure over time, because within the air spaces, the alveoli, they have different time constants, right? Some alveoli may not open even with prolonged pressure over time. Others may recruit relatively quickly, and then you may have some that require 1, 2, 5 seconds, minutes. So it's important to understand that this mode is quite beneficial for the recruitment aspect, because that P high is pressure over time. That's what creates the alveolar stability. So let's look at how we can set up the settings and the parameter for APRV. We have the traditional FiO2 setting, not too complicated there. We have the slope, which controls the steepness of that ramp when we're going to go from the P low to the P high. When we're looking at the P high, okay, we know from earlier on in the lecture, I explained that this should be the CPAP, right? It's setting you into that optimal lung compliance area. But how do we start with initial parameters? On average, the initial P high setting is often between 20 and 30, more so 20 to 25. Keeping in the back of your mind that if the patient is extremely obese or something, this P high might be necessary to go beyond 30 because of the pleural pressure, the weight of the chest pushing on the lungs. So a good way of knowing where to start also would be going to a traditional or a conventional mode. So if you're in a ACPC mode, the good starting point would be the pressure control level, which is usually your peak inspiratory pressure in ACPC. If you're going with the ACVC, the volume mode, then you would set up your protective lung volumes. You would try and find the ideal PEEP, and then after you would take a plateau pressure. And that plateau pressure is where you would start with your P high. If you're in PRVC, as you know, it's always trying to use the lowest pressure possible. So we would take the peak inspiratory flow if you were using it from PRVC to get your P high initial settings. I'm actually going to jump over the P low for a moment, okay? And we're going to go to the T high. So we have the P high that's set at 25, and the T high is going to make that 25 centimeters of H2O sustain itself for 5 seconds, okay? So the T high, on average, a good starting setting is around 5. This is often as an initial setting going from 4 to 6 seconds, and 5 being the average. Understand that if you're sustaining the breath for 5 seconds, and as well as that 0.44 seconds for your T low, you add those together and you divide it by 60 seconds, you're going to see with that how many breaths per minute you're getting, okay? Those airway releases, those are the breaths, okay? So if, let's say, my T high and my T low added together was 6 seconds, therefore 6 divided by 60, that would create a 10 airway pressure release breaths that are going to evacuate the CO2. If I did it and you added it up and it was 5 seconds with your T high and your T low, then again, 5 divided by 60, so now you have about 12 breaths. Don't forget, don't be concerned about the larger tidal volumes on the release. Sometimes they can be up to 12 mLs per kilogram, but don't worry. Don't forget that with this high 5 seconds of P high, there's a lot of gas diffusion occurring. And when you do this, you're recruiting such a larger surface area of alveoli that when you exhale, you might have these larger tidal volumes. Don't be concerned about the larger tidal volumes during the release phase. Keeping in mind that I don't want to give the impression that CO2 is evacuated only during these release phases. Don't forget that this patient could be breathing spontaneously through all the cycles. And that this will create also expiration of CO2. But the airway pressure releases really help take a large bulk of the CO2 out through the process of convection after the P high has used diffusion. So when we go back to the P low setting, it seems like common sense that, we would probably set that somewhere around 5, or at least 3. The button has to be there because if we're setting the T low over there, the 44.44 seconds, and we base that on the patient's peak inspiratory flow. We did the calculation. That's why we set it. And this 0.44 seconds is supposed to trap the gas. So it's supposed to cut off at 75% of the peak expiratory flow rate, right? Remember that we did that calculation. So the thing is that the lung could change, and that flow, that ramp, that steepness could be altered, and therefore at one point the 0.44 seconds might be way off. It might be allowing 50% of the peak expiratory flow rate, or 25 percent of the peak expiratory flow rate to escape, causing serious de-recruitment. So we have to have that P low setting. However, it's not recommended actually to put that on 1, 2, 3 or above. The reason is because the minute that you set anything on the P low, it automatically engages the expiratory valve that's going to create that PEEP, right? And the way we create PEEP with those expiratory valves is we create resistance. So if this is creating resistance, it means that that brief drop, where, like I said, that's where we're trying to help evacuate a lot of the CO2. If that brief release has any amount of resistance, which is going to happen with the PEEP valve, you're limiting the amount of CO2 that can be excreted because you're creating back pressure because of the valve. So because the Draeger C500 offers auto release, it's basically a setting that will always be looking at the peak expiratory flow of the previous breaths, basically, and then readjusting the cutoff time to always, try and maintain that 75% of the peak expiratory flow rate. So you don't always have to worry and go back, and redo the calculations in case the flow ramp and the steepness is changing. So that's what's great about it. So since you're able to use the auto release option, that is again a kind of safeguard, you don't have to set anything on the P low if you're using the auto release, and that will remove that small amount of resistance that PEEP valve would cause. If you even added one, you'd engage that. And because there's such a large amount of CO2 during that bulk ventilation, that release, because there's 5 seconds of diffusion, just a little bit of resistance and back pressure is basically that back pressure is CO2, and it's CO2 that's not escaping. So why limit the resistance, the expiratory resistance? We want to minimize it. Therefore, with the auto release on this specific ventilator, there is no need to set the P low. In fact, setting the P low will cause a rise in CO2 on your blood gases. Basically, how this mode is weaned, right? So as the patient improves, they become less swollen, for example. There's a lot of fluid that was taken off. As their lung mechanics improve, then you'll be able to wean down that P high to match their new FRRC requirement. So obviously, somebody is diuresed a lot. They're looking a lot less swollen. Probably that P high needs to be weaned. So APRV encourages early spontaneous ventilation. It's primarily a CPAP mode with brief evacuations. So definitely an advantage is early encouragement of early spontaneous ventilation. So because it's a CPAP mode, there's low ventilator dysynchrony, there's no trigger, patient's breathing like it's a true CPAP, which is really good because that helps maintain your diaphragm strength and your diaphragm function. We want variations, modes that create a more variation in support helps with the maintenance of lung function. Always that same repetitive inhalation, exhalation, inhalation, the same pressures over and over seem to play a role in weakening your diaphragm. If we can create a more physiological variation in breathing amplitudes and rates, etc., it seems to benefit the diaphragm very much. And we see this in this mode as well. It's definitely a good mode that's creating that variation in the breathing patterns. So when dealing with the weaning phase of APRV, it's basically pretty simple. We want to get them breathing completely on CPAP. So what you're doing is you're gradually stretching out those P high times, causing them to breathe spontaneously at that level. And then by stretching your TI, you're P high, meaning the time on the higher level, then you're getting him pretty much, him or her, the patient, to complete CPAP. As the functional residual capacity, the required positive pressure to help bring the patient back to their FRC. So we're going to be trying also, because they should be improving, right? We're trying to wean. We should be able to give lower and lower P highs as the patient's able to take on spontaneously, more of their own FRC. Extubation can vary depending on establishments. Now I'm basing this on lectures of doctors that are using this, have used it, have done research with it, so they're quite proficient with it. Some I've seen can extubate on PEEPs up to 16. Others want to get them around 10 to 12. Now this is pure CPAP, no additional pressure support breathing above. Some will use the automated tube comp combined with this CPAP, and that's pretty much it. Some will do a challenge, with 0 and 0. I like the idea of, if you're using the Draeger, to keep them on the vent. You get the feedback volumes, rate. You're able to do weaning index, rapid shallow breathing index. So yeah, that's a pretty good idea, and that's pretty much it for the weaning. I do suggest, if you're going to drop the PEEP and really challenge them on the 0, to recruit before extubation, as well as looking at the patient's work of breathing. If you see the patients on expirations almost like trying to force out the expiration, typical, you see this typically in somebody who's obstructed, who's having asthma or COPD exacerbation. They got that air trapping, and they're trying to push out that air to correct the FRC. So if you're ventilating too high, because all of a sudden now you're improving and you don't require so much P high to recruit that needed FRC, then you're going to start like climbing up towards the steep end of that pressure volume loop, and you're going to be breathing on the non-compliant part, the upper part of the loop, and then you're going to see, typically you could often see the patient trying to force out the air, and on the opposite side, for example, if all of a sudden your patient worsens, the chest wall compliance stiffens, then all of a sudden you might be at a suboptimal P high level. And what you'll see there is the indrawing of the sternum towards the back of towards the back. This attempt to suck in air, but you're seeing the chest drawing inward. This is the opposite. This is like the work of breathing is on inspiration. You can tell that the patient's trying to suck in, and it's just like collapsing on their chest. So that you should be starting to think, oh no, I gotta bring up the P high. Probably I'm way below, and the FRC is totally de-recruited there. So it's important to you're going to see it with the flow waveform, and then you can look at the patient also, and it should correlate well. It should give you a lot of feedback and information. Say, I have to reassess this P high level. So in my opinion, it's counterproductive to maintain a optimal PEEP for your patient, but just prior to extubation, you challenge them, you de-recruit them, and then you say, okay, good job. Now I'm going to pull a tube, and you try and maintain that suboptimal FRC, because we just de-recruited you with a PEEP of 0, pressure support of 0. Seems to me that if you like to do that, that's fine, but take the time to not extubate right away, to re-recruit the lung prior to extubation. It's just, to me, seems counterproductive to do that and then to extubate. So for some of the studies, they were allowing a lot more de-recruitment to occur. So they were not stopping at 75% of the peak expired flow rate. They were allowing a complete drop down. So this is not the proper use of APRV. Also, some people were modifying other modes, trying to create APRV. However, often in the traditional modes, there's a trigger that is created on the P high. So not using true APRV modes and kind of hybriding and just setting it up that way on top of it, probably the research had not become proficient enough to really know what amount of air trapping had to occur. So the feedback is that the work of breathing is very difficult for patients. However, those doctors who are quite proficient are able to get patients breathing spontaneously a lot faster. Obviously, that's great for the patient's strength, for diaphragmatic function, and this spontaneous ability to breathe all throughout the cycle will produce a more physiological breathing pattern. Keeping in mind, guys, that P high, when you get the releases, you're really dropping pressure. Notice in conventional mechanical ventilation, positive pressure ventilation, each inspiration is, a positive pressure and then a return to base. So we're blowing the lung up a lot like a balloon. This, we're regaining the patient's FRC and we're allowing a release to evacuate. So it's like a opposite. To release the breath, to me, seems much more protective. I think a big part of why APRV didn't really catch on, because it's an old mode. I mean, I think it was in 1986 or something that it was available. The studies that used APRV were allowing the release phases to go down to zero. So you'd literally be hovering up there on your P high and completely collapsing during the release phases. Obviously, that's not going to be too good. It's not going to really give good results. You're not stabilizing the lung at all. When you look at Dr. Nadir's talks that are on my playlist, what you'll see is that he mentions about the studies and how they were not set up right, giving basically false results. In his practice, he is able to use APRV. They even walk the patients around while intubated. So I don't think that a properly set APRV is a mode that will increase work of breathing at all. Here we see at Dr. Nadir's ICU, patients on APRV that are intubated, that are walking around. These are APRV patients. So I highly doubt that this is a mode that creates a lot of work of breathing, or that you need heavy sedation because it's a reverse IE ratio. It is not a reverse IE ratio. People used to set it up that way, but it's really a spontaneous CPAP mode with brief evacuations. Go see Dr. Nadir. This is me videotaping off the screen of the video. You will find that in the playlist. If you're listening to this, congratulations. You made it to the end of my video. Please subscribe to my channel, guys. Press notifications so when we do a new video, you'll get a notification. Please go see my playlist. There's a lot of lectures. There's a good repository of videos. Stuff on from radiology, APRV, specific modes, mechanical ventilation, waveforms. The site, I think, is very good, not only for RTs with experience, but RT students. Even to a certain degree, some of the videos might apply for nurses. and I'm going to make different degrees, some for residents, some for students. It's a new channel. It's just it's been about 2 weeks, so it's going to get better and better, hopefully. Thank you again for encouraging it, and pass it around to all the other fellow RTs and to any residents that are interested in understanding mechanical ventilation. Bye guys, see ya.